Okay. And these are our learning objectives for today. How does depression present in children and teens? How do I screen for and assess depression? How do I determine the severity of depression and appropriate treatment? And so just as a quick check-in, everybody, if you could just type into the chat, your name, your organization, just kind of as a quick way. And the quick check-in question might be, are you seeing an increase in adolescent depression among your own patients? Okay. So I don't have it set up as a poll, but I'm just kind of curious. Are you seeing this big jump? Is this an issue that you're dealing with now? So go ahead and start typing this into the chat. And none of the organizers or the speakers today have any major disclosures to share. So before we get into the slides, I want to go ahead and introduce our speaker for today. We have Dr. Eileen Wang, who is one of our child and adolescent psychiatrists here in the CAP program. You might have spoken with her if you've ever called in. She'll be presenting on depression today. And these slides were based on some materials previously presented by Dr. Michelle Roederer, another one of our CAP consultants. So with that, I'll turn things over to Eileen.
Thank you, Joanne, for the introduction. Hi, it's nice to see you guys. So today we're going to focus on a couple bullet points about adolescent depression and children depression. And it will be a rather shorter presentation, and then we'll move forward to the case and then look at the case together. So what is depression? It presents differently in children, adolescents, and adults. For children and adolescents, there are some minor differences, but irritability is often the most common first symptoms of depression in kids and teens. There are also somatic complaints, headache, stomach ache. These are pretty common when younger children presents with depression. There are also behavioral problems for teenagers that could be decreased engagement in school, poor performance academically. So when your patients who are children or adolescents that presents with these symptoms that are not typical to when you think of adult depression, it might not be similar with adult depression's demonstration and presentation. When we try to approach patients' depression symptoms, it's always helpful to ask the parents and teens or children separately, because parents tend to report externalizing symptoms. It's hard for them to know what their kids really feel internally. So usually parents would say things like they're really angry, they throw a lot of tantrums, they always seem unhappy. Parents can complain about bad behaviors, while the teenagers and children can report something that's quite different, saying that they feel it's really difficult to be motivated, it's really difficult to get up in the morning and do work, it's really difficult for them to be excited about school. And then hopelessness, helplessness, usually parents would not be aware of that. So we really need to acquire those symptoms from the teenagers and children. Next slide, please. The screeners for depression, I think most of you are very familiar with PHQ-9 already, and that's part of kind of the first step screener integrated in a lot of the primary care clinics already. It's validated for teenagers. So for patients that are 12 and younger, I would often use the other one, short mood and feelings questionnaire, that's valid for age 8 to 18. It's just because the way PHQ-9 is written, the language is a little bit more mature, and sometimes it's hard for younger kids, like an 8-year-old or 9-year-old, to be able to understand what that's really referring to. They're both pretty short and easy to administer during the clinic hours. The cutoff for PHQ-9 is under 10, that's mild, and then between 10 to 20, it's moderate to severe. And then when it's above 20, then it's indicating severe depression. For short mood and feelings questionnaire, the cutoff is 8, and there's just one cutoff value. Next slide, Pete, please. After screening for depression, once you get a sense of what is the severity of the patient's symptoms, then we can have a deeper dive and then ask different kind of questions that will be our clinical interview of the patient's symptoms. So first, the psychosocial history using the HEADS mnemonic is very helpful. It really covers most of the things that we want to know when we see a patient with anxiety and depression. We also want to assess their function, because if they just have very mild depression symptoms that is not impacting any of their function within their family, as to their family roles or their peer relationship or their school performance, then there might be a different way of treating it. There are also acute stressors on top of the depression symptoms. There might be, like we know recently, there are unfortunately a suicide in Berkeley High. So there are often different kinds of stressors that can make a chronic depression more acute in the current moment. And there are also chronic stress, including trauma, including different types of abuse history that we can detect from doing the pearls and ACEs screening. And finally, the clinical interview will include the parts that you're going through the nine symptoms of DSM-5 criteria for depression, which we'll review shortly. The way to assess for depression after doing the screening is first you sort of interview the patient and parent together briefly to get a collective sense of what's been going on, and then separate the patient and parent. You will discuss with your teenager about confidentiality. Usually the way I talk about it is I first ask them whether they know what is their understanding of confidentiality. Some of them surprisingly know quite well about what it covers. And then I will praise them for knowing the word, and then add a little bit more to discuss with them that I will use my best judgment to alert their parents and any authority if there's any concerns for self-harm or anyone's harming them, hurting them, because I'm a statement data reporter. But before I move on and do so, I will for sure discuss with them first to figure out a way whether we want to deliver this message together to their parents, or they can choose to tell their parents about it themselves. I will also be brave to ask anything that I'm concerned about, because most teenagers would not volunteer for their symptoms. If you ask them, how do you feel? They'll be like, fine. And that fine doesn't really mean that they're fine. So usually I will probe a little bit more, or even use some humor and say, you don't really look fine, even though you're saying that you're fine. And I'm smelling something that you may be worried about, blah, blah, blah. It's also really helpful to use normalizing statements. A lot of teenagers don't really know that they're not the only person in this universe that's depressed. So they're often surprised and feel more validated knowing that this is very common. There's a 15% to 20% rate of depression among teenagers. And this is a question that I ask all my teenage patients, or many teenagers actually struggle with anxiety, with sadness. Then having collateral information after you interview the teenager, talk to the parents separately. If necessary, it will also be helpful to get history from the teacher to observe their school performance or their peer relationship. If they do have a therapist, it's also helpful to get some information from the therapist. Next slide, please. And here is the diagnostic criteria for depression on DSM-5. The first prerequisite is to look at whether patient has depressed mood or loss of interest, which is anhedonia. And then if they do fulfill either one, then we go down and see if they also have other symptoms and whether there is a presence of 5 or more of the following symptoms during the same 2-week period. And then as you can see, their depression, insomnia or sleeping too much, interest, loss of interest, worthless, hopelessness, lack of energy, reduced concentration, lost appetite or increased appetite, psychomotor agitation, restlessness, or retardations, which is the patient feeling malaised and not having energy to move. And finally, any suicidal ideation plans or actions. And then when we're going through the criteria, we will focus on the severity of the symptoms, whether it's mild, moderate, or severe, and the level of distress. And finally, whether it causes any functional impairment to the patient's role within the family, in the community, with their peers, and at school. Next slide, please. After we completed the screening and interview, there are a few other things to think about. One thing is differential diagnoses and other comorbidities. In children, the common ones are anxiety disorder, disruptive behaviors, ADHD. In teenagers, ADHD is still high on the list. And also there are other types of behavior disorders, including oppositional defiant disorder, substance use disorder. And at this time, there will also be possible concerns for bipolar and psychosis, because at around the age of 15, 16 is the time of early onset psychosis and bipolar disorder. So that will be a very rare condition, but sometimes we will take that into consideration if there are enough concerns for that. Medically, there are a few things that I will also check out if the patient do present with possible symptoms that make us be concerned about hypothyroidism, mononucleosis, anemia, and so on. I don't necessarily always order labs for all of these conditions, but if there are any other concerning symptoms, such as very abrupt, sudden onset of depression, or a typical presentation of the depression, and or the patient have other type of physical symptoms along with their depression symptoms, then that will be the time that I think twice and then consider ordering more labs to rule out other medical causes. And earlier we talked about stressors, evaluating whether the patient has any acute stressors on top of their depression symptoms, and or whether there are other medications they're taking that could make the patient feel depressed. Stimulants and corticosteroids tend to make patient more irritable versus contraceptives. There's a very small risk that may cause the patient be depressed, but none of these is super common. So these are kind of zebras, but I will still keep that on my list. Next slide, please. And here is a treatment algorithm that we also have on our UCSF CAP website. So this sort of concluded what we just talked about. When we see a teenager, we screen, and then we regularly screen them and see if there is any depression. The screening tools that we recommend are PHQ-9 adolescent and short mood and feeling questionnaire. And besides the screeners, we also do a safety check to rule out any trauma and any suicidality. And then after the screening and safety check, then we have a deeper dive and look at the DSM-5 criteria, separate the patient and parents, get collateral information, explain and introduce the idea of confidentiality. And then we determine, based on the patient's functionality and severity of symptoms, we'll divide them into mild, moderate versus severe group of depression. For the mild patients, they don't necessarily need to be started on medications. These patients might have a PHQ-9 score that's a lot lower than 10. And really the rule of thumb is to follow up with them in 2 to 4 weeks, continue to track the rating scales, track the PHQ-9 and other rating scales that you might also want to collect in another month, and then safety assessment at each visit to kind of see if they have any new suicidality or any thought of hurting themselves. For the moderate and severe patient, we can also do the same thing: psychoeducation, supportive therapy, follow up with them regularly in the first 2 to 4 weeks. And on top of that, start them on psychotherapy and considering starting antidepressant concurrently. For the severe patient whose PHQ-9 score is above 14, so above 15 and up, starting psychotherapy and SSRI treatment for 3 to 6 months. And if the patient during this period doesn't seem to have any improvement, there are some factors that will make us think of referring to child psychiatry. That are, the patients have moderate to severe symptoms along with safety concerns, recent hospitalization, and or having other types of comorbidities, including substance use disorder. This is usually a tough one. When the patient also shows signs of mania or psychosis, this is also another indicator to refer to child psychiatry. No response to the SSRI after 6 to 8 weeks. And then if the patient has failed more than 2 medications or have been on more than 2 medications and still experiencing depressive symptoms, these are the more severe patients that will be appropriate referrals. Next slide, please. So we talked about offering psychoeducation, supportive therapy, and active monitoring to all patients. And this is actually the first step for mild patients. But for our moderate and severe patients, besides psychotherapy and medication, we will also recommend these measures. But how to do them, and then what does that really sort of encompass? For the psychoeducation interventions, these are the things that we will offer patients. So go over sleep hygiene, recommend, really emphasize the importance of regular exercise. And I can't really see the slides, and I don't know if that, okay, now it's clear to me. And optimize their self-care, making sure that they are following the regular schedule, being active during the day. They can also try gratitude journal. Using the mood tracker can be helpful too, for them to see the changes of their mood throughout the day and also across a week or month. And really encourage behavioral activation. So again, that's making a schedule and making sure that they fill their schedule up with different types of activity, so they're not left alone to be withdrawn, to be isolated. And the other part of the psychoeducation is teaching them about relaxation strategies. These are a few examples: the belly breathing. And for younger kids, you may teach them to put a toy on their belly and observe. Take a deep breath and observe how the toy moves up and down on the belly. The other really good one is progressive muscle relaxation. And also for the younger kids, they may have to sort of imagine the ragdoll and imagine that they tense up their muscle before they relax their muscle. It's really important to emphasize tensing it up, because it's hard to relax your muscle before it's fully tensed up. Imagery practices for older kids, imagining a calming place, the beach, or being in the tree house. And also for older kids, for teenagers, mantra may be helpful. Teens mostly have cell phones, and here's the time that will encourage them using their phone to access the apps for relaxation strategies and mindfulness practices, such as Headspace, Calm. There are several really good mood trackers on the that I have seen in the app stores, but I usually just put in mood tracker, and there's multiple different ones that are rated more than 4 stars that I have recommended my patients. Next slide, please. In terms of psychotherapy, these are the two that are with more evidence showing its efficacy in treating teenagers' depression. They are CBT, cognitive behavioral therapy, and IPTA, interpersonal therapy for adolescents. It's easier to get a therapist who has certified in CBT. IPT is a little bit less available and harder to find. But really, if the patient can get a therapist and just start from there, it's mostly helpful and better than not having therapy at all. When I do refer patients for therapy, either through Psychology Today or Access Line, I will encourage them, or I may call on their behalf if that's needed, to advocate for a CBT therapist to begin with. And then I will usually tell the Access Line or help them to find via Psychology Today to use the filter or keyword of having a CBT therapist for anxiety or CBT therapist for depression based on the patient's condition. Next slide, please. And finally, here comes the medications. SSRIs are the first-line medications when it comes to treating depression. These are the 3 top medications that we often start with: Prozac, Lexapro, and Zoloft. For patients who are they're younger than 13 years old, usually I start from half of the initiating dose. For Prozac, the starting dose is generally 20, but for younger patients, I start from 10 to 20. Lexapro, I usually will start at 5 milligram, and then for sertraline, Zoloft, I'll start at half of the usual starting dose, 12.5 for younger patients, and then for teenagers, I will start at 25 milligrams. The titration for Prozac is 10 milligram increments, and the maximum dose is 60. For Lexapro, the titration dose is 5 milligram, and the maximum is 20. And then for Zoloft, it's 12.5 to 25 or 25 to 50 based on the age, and the max dose is 200. There are individual side effects of these medications. Prozac has longer half-life, so it's a really good choice when the patient has poor medication compliance, because if they miss the medication 2 or 3 days in a week, the meds is still largely staying in the system. There also tends to be less withdrawal symptoms, and that's the reason why it's a better choice for patients with poor medication compliance. It can be more activating, so patients can feel more jittery, restless, or even having increased anxiety in the first 2 weeks or when the medication dose is titrated. The FDA approval age is for really young kids, so there's less concerns about this medication is not studied well enough for kids who are like 8, 9, or 10 years old. Lexapro tends to be thought to be a medication of mild side effect profiles. About 30% of people can feel tired when we first initiate it. So usually when I start Lexapro, I start at bedtime, unless the patient does feel activated on it, then I switch it to the day. The FDA approval is for age 12 and up, but it doesn't stop me from prescribing it to younger kids, just because I don't think the pharmaceutical company is interested in doing another clinical trial in order to just get the medication be approved for a pretty small market. And it has been widely used clinically for even kids who are younger than 12. Zoloft is also approved for a pretty young age. It can be, it's also considered to be with less side effects and a milder medication. The only downside that I find is the titration period can be quite long, because when you start at 12.5, if you want to get up to 200, for some family or patients who are very anxious, they might feel you're always titrating a medication. So it's a milder medication in terms of side effects, but if the family has a lot of anxiety about going up every time on the dose, other choices might be better. Next slide, please. And finally, here are some resources for family to understand better about how depression looks really different in children and adolescents. The explosive trial also talks about children's anger tantrum, because it might be a manifestation of their depression. They're really trying the best that they can, yet they're feeling a lot of these anger because it's an externalizing symptom of their mental disorders. And then this is a DBT book that helps parents to understand, and parents and teenagers to understand how to deal with self-harm.